Hello and good morning, good afternoon, or good evening, depending on where you are in the world. My name is Kevin Joles. I am the EMS section chair for the IAFC, and I'm joined today with a great panel of speakers to talk about reimbursement with mobile integrated healthcare. I will go ahead and get started. So before we begin, audio is being broadcast using voice over IP technology through your computer speakers or headset. Please make sure that your speakers or headset are turned on and the volume is turned up. Audience microphones have been muted for the duration. If you experience technical difficulties, please contact the IFC support at via the chat function. In the upper right corner of your screen, you'll find the chat and QA menus. You'll be encouraged to share comments and submit questions throughout the conversation for the speakers. If the presenters have provided resource materials or links, you'll find them in the handout section as well. We want to, of course, thank our sponsor, Public Consulting Group, or PCG. They've been a great partner for the IFC, specifically us in the EMS section. We lean on their advice and their consulting quite a bit, and we appreciate all their folks. And we've got Sarah and a few others today with us. So thank you for your support, Sarah.
You are.
I will let Sarah introduce everyone today, but as we get moving, again, a great panel of speakers that joining us today, and a lot of insight, and I'm looking forward to the next hour.
Thank you so much, Chief Joles, and thank you to the IFC for having us here today. We're really excited to come to the table with this topic because, as we've seen more and more, it is a hot button item. But not only is MIH and community paramedicine something that I think is growing in our industry, but it's also a question of how we are going to sustain these new service delivery models. And that's what we're going to be talking about here today. As mentioned, we've got a great panel across a number of different kind of areas of expertise and backgrounds that we really want to gain as much knowledge that we can from each and every one of them. So we will dive into that panel discussion about halfway through our presentation, but we did want to start off a little bit today on just kind of the foundation of what you might already be experiencing, some avenues you might already be exploring for funding when it comes to your own MIH program, or if you are somebody who potentially hasn't started a program within your department but are exploring those options. I believe you'll get a lot of information on kind of those first steps to conquer as you're developing a program for your community. So on behalf of PCG, again, my name is Sarah. I'm accompanied here by Nora. We will be giving kind of that basic overview of some MIH funding opportunities, and then I will be moderating the panel discussion. Our panelists on the screen today, you're definitely going to hear a lot from them a little bit later on, and they'll do a better introduction than I can serve justice on. But we do have Deputy Chief Steve Bowie on the line, as well as Chief Justin Lemire and founder Joe Phillips with us on that panel discussion. And like I said, they'll give a little bit of kind of what they're doing in the industry, the programs they've set up, and then answer some of those really doubting questions that we all have about how they've been able to sustain and even flourish their own programs. So without further ado, we'll go ahead and go ahead and jump right in. We do have some time set up for the end for Q&A. We do hope to be able to get to those. So please, as Chief Joel said, drop those into the chat. We'd love to hear from you. Make sure that you're getting the most out of this presentation. If for some reason we do not get to that question, just know that PCG will follow up directly with being able to provide the answers that you are looking for, or you're always welcome to reach out to us separately. Here's our agenda. I kind of already went through what we're aiming to get done today in this next hour. And with that, I will go ahead and let Nora kind of jump in here and get us started with, again, some of that foundation of what to expect on setting up an MIH and how to secure some funding for it.
Thank you, Sarah, and thank you all so much for joining us today. So to begin, we want to start with a poll just to gauge what those of you in the audience would like to achieve from implementing a mobile integrated health program or community paramedicine program. So the poll question reads, what would motivate your department to implement a mobile integrated health program? A, reducing unnecessary 911 calls and ED visits. B, improving community health outcomes. C, securing sustainable funding and reimbursement. Or D, all of the above. So please respond on your screen to indicate what you would like to get the most out of implementing such a program. There are many different reasons for why these programs are designed and implemented in communities, and we want to hear from you on what would be most impactful.
And I believe if you want to drop your answer A, B, C, or D, just that letter, you are welcome to do so in the chat so we can kind of see who's putting in what. And Nora, I don't know if we'll be able to see those live results, so we could just take a look at that chat to see if you see any themes or anything like that, and then we can kind of move on to the next slide.
So far, I'm not seeing any answers populate on my end, so I think we can circle back to it at the end, especially after sharing this information, and see what everyone gets out of it.
Sounds good.
All right, so setting the stage. So what is mobile integrated health and why does it matter? So mobile integrated healthcare and community paramedicine programs represent a fundamental shift in how EMS operates. According to IAFC, mobile integrated healthcare is a cost-effective way to provide the right care for 911 callers who really don't have those true emergencies. So instead of sending that full emergency response, MIH uses professionals like EMTs, paramedics, nurse practitioners, or physician assistants to handle these cases. So it's not replacing that traditional EMS response. It's just creating an additional component to really provide that patient-centered care. The National Association of Mobile Integrated Healthcare Providers states that mobile integrated health is a patient-centered care model that uses those coordinated teams, so the EMS clinicians, nurse practitioners, and other professionals to provide care in safe, out-of-hospital settings. So community paramedicine is a part of MIH, where EMS providers are taking on an expanded role to deliver care and improve efficiency. So traditionally, EMS has been viewed as a skilled transport service, but MIH programs really define that role and focus on the patient-centered care delivery system in the out-of-hospital environment. This matters because EMS agencies across the country are facing those overwhelming call volumes, and many of those calls are coming from individuals who actually don't require that emergency assistance. And often these patients call 911 because they don't know where to turn. And there are other ways that we can address that type of care that they need in the out-of-hospital setting, either in the community or the home, to reduce those unnecessary emergency department visits and really improve system efficiency as a whole. So it's important to note that these programs aren't one size fits all. As the saying goes, if you've seen one EMS system, you've seen one EMS system. So every program is going to be different and shaped by your community demographics, infrastructure, stakeholder priorities. But a huge component of this is that alternate care systems. So they're really helping to divert those patients away from hospitals, keeping those ambulances available for true emergencies. So there are a lot of different models, but today we're really going to focus on the funding component. So the evolution of mobile integrated health and community paramedicine programs really reflect a major transformation in EMS. So like I said, historically, EMS was seen as that skilled transport service, really a way to get a patient from the scene to a hospital. But that model alone is no longer sufficient or sustainable given our growing needs in our communities. And EMS must really evolve to be part of that allied health field, integrated in that broader healthcare system. So one example of this, the COVID-19 pandemic accelerated this type of shift for a lot of providers. And one really great example is in Melville, Missouri, where before the pandemic, they were getting ready to expand their higher utilization program. But when that pandemic hit, they quickly shifted. Instead of relying on overtime from their current staffing base, they hired full-time employees completely dedicated to the mobile integrated health efforts. And they used that team to rapidly respond to the pandemic. So what they did was they went out in homes and in the communities to test those who were showing symptoms of the COVID-19 virus. They administered vaccinations right into the community, and ultimately patients were able to remain at home and avoid the unnecessary trips to emergency departments. So this is just one example of how these programs are constantly evolving and shifting based on your community needs. So while we are primarily focusing on funding today, the foundation of any successful MIH program is going to be a needs assessment. So it ensures that the program is really addressing the real needs and care in your community and aligning with priorities. And this process begins with data collection, so analyzing EMS call data, hospital utilization patterns, social determinants of health, and helps to identify those frequent emergency department users, the non-emergent 911 calls, and chronic disease management challenges. The next step from there is to engage stakeholders like hospitals or payers to really understand their perspectives and how everybody can work together as a team. From there, it's important to conduct a gap analysis or a needs assessment to really pinpoint where patients might be falling through the cracks and where there's more opportunity for additional care coordination. And the outcome of this type of a program is really tailored to your community needs that are clinically relevant and financially sustainable. So throughout this, it's important to make sure when you do set up a program, using data modeling to track how these programs are helping to reduce costs in your communities to report out to stakeholders is extremely important. So mobile health offers in-person services like physical exams, vaccination, counseling, preventative health screenings, but every program is going to be different. So with some MIH programs, you can focus on a single service like infectious disease testing. You can also focus on a population like rural county wellness, or focus on the centrality of a vehicle to deliver care where people are at. And here we have some examples of programs that are going on in different communities across the country. So I mentioned Melville, their program in Missouri, where they really adapted to help patients during the COVID-19 pandemic. And Tempe's patient advocate services really show that they're able to integrate not only health services, but also services for all needs of a person. So healthcare, housing, food, telemedicine, and really took a holistic approach, showing how every program is a little different.
Nora, I'd love to call out real quick the result that you have under Tempe, that 46% reduction in non-emergent calls post-enrollment. I mean, if you can imagine as a department that isn't getting funding on some of those treatment in place or non-treatment calls, this type of program put in place could not only bring money into your department, but also save you money on not having to respond to some of those non-emergent calls that might become overwhelming as your resources are more and more limited.
Thanks, Sarah. And jumping into, the limit in those resources. And so here we really want to focus on funding and rate setting. So when setting rates for a community paramedicine program, you really need to start with a full analysis of costs, potential savings, and overall financial impact of the services that you plan to offer. So as we all know, traditionally EMS reimbursement is tied to those patient transports. So treating a patient on the scene and providing that transport. But when you don't have that transport, that can create a sustainability problem for ground ambulance services, since that's how they're traditionally reimbursed. A treat no transport or community paramedicine payment model really solves this by allowing providers to bill for that type of care that's delivered on scene. To do this, to find these rates, they must be actuarially sound and based on cost-based methodologies, Medicare, Medicaid benchmarks, and validated through actuarial analysis. So this is going to make sure that these rates are defensible. But where it gets interesting is there's also environmental factors like rural or super rural areas that really can impact what these rates should be. So, for example, in a super rural area, your cost of readiness, so keeping your crews and equipment available for a longer response time, that's going to be a much higher expense to a department than in an urban setting. So it's meaning that all of your rates must factor in that cost of readiness, even if the call volume is low. Service classification matters too. So if your program is using advanced level clinicians like paramedics or nurse practitioners, your labor costs are going to be higher, which should in turn impact those rates that you're setting. If your rates are too low, you'll lose money on the program and it won't be sustainable. But if your rates are too high without that solid justification, that actuarial analysis to really make it defensible, then payers won't reimburse you. So it's really critical to back up your rates with the real data from your department and show the value that your program's bringing. So how it's reducing hospital stays, preventing emergency department visits, and really saving the whole healthcare system in your community money. So how do you set the rates? You start with your actual costs, you add adjustments for service level and rurality, and then you have to validate those rates against benchmarks and actuarial analysis. So rates should be reviewed periodically once you set them. That doesn't mean they're set in stone forever, as you should continue to readjust based on inflation and other changes in the program. So these services, how can they be billed? Well, many programs use negotiated rates with payers, bundle payment, or per visit fees. There is some states that allow Medicaid reimbursement for treat no transport models. There are some models of these programs that use a subscription basis. So there's all different types of funding mechanisms. So now that we've talked about that rate setting, we're moving into the next critical piece, which is how providers can actually bill for these community paramedicine programs and get reimbursed. So billing for these programs needs to move beyond those traditional transport-based codes. Historically, EMS billing has been tied to taking a patient to a hospital, but that doesn't necessarily fit the mobile integrated health model. So instead, providers should look to use the CPT evaluation codes, which are the codes that reflect the actual clinical work community paramedics are doing, like assessing patients, making decisions, providing education, and coordinating care. These programs allow for clinical evaluation and management services provided during a community paramedicine visit to be reimbursed even when there isn't a transport. These can be billed for, but only when EMS agencies have qualified clinicians that are performing these clinical assessments. So often those are paramedics, nurse practitioners, physician assistants. The encounter must be very heavily documented with all of the necessary paperwork on what happened during the evaluation, the decision making of the provider, and care coordination. It has to meet CMS standards. And there's also a credentialing and compliance piece where EMS agencies must enroll as providers with payers and ensure their clinicians meet these scope of practice requirements. So documentation is key. Medicaid reimbursement is another way many states could help provide additional reimbursement for these programs. Medicaid often reimburses for things like telehealth visits, non-emergency transports, and treat no transport models. It's also important to negotiate rates with payers and implement hospital partnerships to make sure these programs are sustainable and you're able to receive additional reimbursement as you are providing these services. And we have that pathway, but we also have other pathways where you're able to tap into additional funding to either start up these programs or continue to receive reimbursement. So if you were to start a mobile integrated healthcare program, how would you plan to fund it initially? Are you looking to allocate a percentage of your budget to startup costs? Are you looking into state and federal grants, which is a popular avenue? Are you looking into those payers, partnerships with payers and hospitals? There is a plethora of different funding mechanisms out there to help provide that initial funding for those startup costs. And we have a list of them here. We won't be getting to all of them today, but one that I really want to highlight is the Rural Health Transformation Funding Program.
All right. I'm so glad you said that, because if you didn't, I was going to highlight it for sure. As a consulting company, we've looked at about 31 applications from different states on the rural health transformation funds. And of those 31, about 25 do mention EMS specifically as an initiative that they would like to put some of those funds towards over the next 5 years. Now, the initiatives definitely vary from state to state, but one of the common themes that we were able to pull out is that MIH component. So there is a big push on this rural transformation outlet to be able to use the money towards setting these programs up. And as we've kind of emphasized already, making sure that they are sustainable, because that is a large component of being able to continue to receive the rural health funds over that 5-year period. So we mentioned data and how important it is from the onset of even thinking about a program and setting the rate, but you also need to look at data from the component of sustainability, actually showing its value, benchmarking against industry standards. And we might not have industry standards. That's a good question, I guess, to throw out to everyone here, is what you would consider an industry standard for MIH. But with lack of kind of more well-known standards, because it's so new, that what are you comparing yourself to? Is it a neighboring department? Is it the gold star department that you want to get to? But how are you really measuring results and showing the outcomes of your program? Big factors, not only for the rural health, but really in all of these particular funding mechanisms that you see on the screen today. Because if a hospital is going to give you $1 million every year, they certainly want to know where that $1 million is going, and that it really is making an impact to patient care and financial durability. Sorry to have jumped in, Nora. Back to you.
No, thank you, Sarah. You hit on a lot of what I was going to cover, where it's really important that you align your program design with the rural health transformation priorities. And that requires careful planning in order to tap into this funding. So careful planning in terms of those partnerships, tracking your data, tracking how this can really benefit your healthcare system and save you a lot of money in the long run. So this isn't just about, checking off the boxes, filling out an application. You really have to structure your program so that it meets the fund's goals and really positions your department for long-term success. So agencies that leverage expert guidance can move faster, avoid any compliance pitfalls, and really maximize funding. So for example, if your program focuses on reducing those hospital readmissions, you'll want to design workflows and data tracking that clearly demonstrate those outcomes, and also communicate that with the stakeholders involved in your program. If you're in a super rural area, you might need to show how your program addresses long transport times and improves access to patient care. These details matter because they can directly influence funding approval and tapping into these types of funds. So it's really important to have a plan when you're setting up your program to know, how are you going to track these metrics? How are you going to communicate these metrics with stakeholders? And how are you going to make sure you're remaining compliant if you are using these types of funding programs? So just a question to think about: what is your biggest barrier to launching a program like this? Are you most worried about lack of funding or reimbursement options, staffing and resource limitations, uncertainty about community needs, lack of knowledge on where to start? Wherever that barrier is, there is a way to get around it with careful planning. So there are lots of experts out there that can help you tap into funding, set up these programs so they remain compliant, so they are sustainable, and you can use funding like the Rural Health Transformation Program.
And if you're not certain whether or not your state has that EMS initiative in the application for rural health funds, you're welcome to reach out to PCG. But of course, it is best for you to go ahead and start getting engaged with your EMS community. So whether that's your association, your bureau, or any other outlets that you have to kind of learn more about what's been put aside for EMS and how the state plans to spend that money. Because even though it does say rural, That doesn't mean that a department in an urban area or a metro area can't receive funding, but it will be dependent upon how you're going to support the rural community and patient care outcomes.
Thank you, Sarah. And to close out this section before we get into the more conversational piece and forum of this presentation, just want to leave you with another poll to think of. So drop your answers in the chat and we will take a look at it as we go through the duration of the presentation. But do you know where to start when it comes to building a program? A, yes, you have a clear roadmap. B, you have some ideas, but maybe need some guidance. C, no, you definitely need help from experts. Or D, you haven't even thought about it yet, haven't even began starting your program. Drop your answer in the chat, and as we go on, I'll take a look and we can share a recap at the end.
Thank you, Nora. Really appreciate all your insights and good information that you were able to set us up with as we do get into the next section of our presentation, which really brings in our real world experts to answer the questions that maybe you all have had at the top of your head. Maybe now going through the first part, you're starting to spin those wheels a bit and you want more answers and insights to how these programs get set up and how they do get funded. From departments that might be similar to yours. So with that, I'm going to start off with welcoming Deputy Chief Justin Lemire to the table and letting him have the floor to introduce himself, the department that he works for, and tell you a little bit about MIH from his view. Chief, it looks like we can't hear you.
Can you hear me now?
We can. Thank you.
Thank you. I apologize about that. Thank you, Sarah and Nora, for that presentation. I enjoyed that very much. So my name's Justin Lemire. I'm the Chief of EMS for the Tulsa Fire Department. I've been on for 19 years, serving in my current position for about 6 years, running the EMS and mobile integrated healthcare for the Tulsa Fire Department. And so we are coming up right now on 10 years. It's about 10 years of running MIH services with the Tulsa Fire Department. So we started right around 2016, really started a little bit before then. But really in 2016 officially started. And so very excited about what MIH has done for the Tulsa Fire Department and our community. When you look at MIH in Tulsa, when I first got in here during COVID in 2020, we had 3 dedicated members for mobile integrated healthcare. We had 3. As it sits today, we have 18. So we've really exponentially grown in our mobile integrated healthcare from 3 to 18. And we staff all sorts of positions. We have nationally registered paramedics. We have community paramedics. We have case managers. We have peer recovery support specialists or PRSSs. We even have a couple RNs in our program. And when you look at our teams from last year, we made a little over 5,000 responses for MIH responses. And we really have leveraged data agreements and data sharing with community partners to really enhance our program, utilize software to get us there, and really has shown impact not just to our department, but our city leadership. So I'm really excited to answer some of these questions today and talk with you all about mobile integrated health.
Well, thank you so much. That is amazing. 5 to 18. I can't believe it. In a short amount of time too. So what got you started with your program? Did you, as Nora said, do an assessment, or was it pretty obvious there was a need in your community?
I think this is something I discuss with a lot of departments that I talk to. Is where do you start? And so I think every one of us on here, you're obviously going to look at your own department first. What are we responding to? What are the pinch points? And what I like to look at is response trends and using data, like what are our most prevalent call types? What parts of the city are those in? What are some of those low acuity calls that maybe we're not answering or changing that outcome by our emergent response? So we send a fire truck, we send an ambulance, but guess what? we're going back over there again and again and again because we're not really solving any of those issues. So we looked at that type of data and determined what is our department facing. And then we looked at the community health needs assessment. So every community should have one of these. A community health needs assessment really dives into those prevalent risk factors, those factors that are impacting your community. And health department is usually part of it. Hospitals usually coordinate with those assessments and a number of other community partners. But really, we looked at that community health needs assessment and said, what is impacting our community? And really for us, it was stress and mental health, chronic disease management like CHF and COPD, healthy and affordable housing were a couple of the top three identified needs. And then really, I got engaged with those groups. I got engaged with the health department and the hospital. And this is something that I really encourage anyone out there who's not. You got to plug in to your community. I say for now, 75% of my work is done outside of the department. I'm in the community with these different partners and agencies all the time, making sure the fire department has a voice and this healthcare has a voice, healthcare approach. So we really looked at our department's response. We looked at the community health needs assessment and we aligned and we said, let's match these and how can we address these? And so for that really looked like high utilizers of 911 system, aging in place population, crisis response, addiction recovery, and homelessness response. We really looked at addressing those issues with our MIH services.
Great. Well, thank you for that. And how have you been able to fund and receive reimbursement for the services that you are offering through your department?
Yeah, so funding from us is multifaceted, and I think anybody who's in here is or part of this webinar today would understand it's really taken some work and a lot of conversations. So funding from us has come from municipal, private, and grant. That's really been our three primary funding sources up into this point. And when you look at municipal funding, that constitutes about 38% of the funding of our programs. Grant is about 40%, and then private funding is 22%. So we've established those relationships very intentionally with some of our community partners. We've done a really good job of selling or illustrating the value of what we do to city leadership, and they've really bought in and really enhanced or scaled up some of our programs on their own accord. Reimbursement. We have contracted with the state now. As we talked about earlier, we have case managers and peer recovery support specialists on some of our teams. We have some of those multidisciplinary teams. By accomplishing that, we've become a contractor of the state, which has opened up some doors for us to build through some of those licensures. So we do have some bills that are being presented, and they're going to be presented in the state this year that will help with treatment in place, some of that alternate transport, and mobile integrated healthcare. We're hoping to move some of those forward or at least get those a little closer to the finish line.
Wonderful. And as the chief of EMS, I'm sure this is something that you deal with every day, but that balance between running an MIH program and still having to, of course, keep up with the demand of your emergency response staff. How are you handling that?
Yeah, well, the first thing I would say about EMS and MIH is these complement each other. MIH complements your emergency medical services. What I always love to Dan Heath talks about upstream thinking. And so I use this illustration quite a bit with upstream, midstream, and downstream. So when you think of downstream, you have to think of your frontline response. How are we responding to these emergency calls? There's always a real need for someone to respond. We have to have that downstream response. Where we found that increased value is the midstream, where you begin addressing those socioeconomic factors or that chronic disease in the midstream area, which is where you address those root cause issues of why someone is calling 911 services. So I say that to say is those complement each other, and you must really have those. And MIH has impacted our operational demands in a big way. When you look at it's a reduced frontline response. When we implemented one of our programs called Alternate Response Team 2 that responds to unhoused population in our downtown area, it immediately dropped frontline response by nearly 30% at two different fire stations. And we saw this go down. This was a big win for our frontline responders who are on the fire trucks. This is obviously they're very happy about some of these calls. It was a big win for our city leadership because we were addressing a city priority. And the people who have working on the trucks enjoy that work because they're actually solving some of these reasons why people call 911. So I say we balance that by MIH helps take some of that burden and load off of emergency response and really complements it in a big way. And as we look at what the fire service is about, I believe that really and emergency service work, it's about prevention. How are we preventing that next call, right? Or how are we preventing that emergency in the first place? And I believe there's going to be a lot of financial incentives when you look at the landscape coming into 2026 is how can we, improve that outcome and prevent that 911 caller from using that service or from going to the emergency department and really by improving those outcomes and reducing those readmits. So.
Absolutely. Yeah, it's interesting that you brought up that because we work with a lot of departments that are considering, that are fire only, that are considering bringing on EMS. And that whole culture balance of like, well, our firefighters don't want to do EMS or they don't want to change. And like, they see it as new, right? And most people aren't really happy about new. But the fact that it actually does serve them in the long run and you can state that, make that case and help ease them into it. And show those benefits long term, I think is a really great point for everyone here to hear today. So thank you for that, Chief.
Absolutely.
I would love to continue on to these other questions, but I'm going to jump over. We're going to hear now from Joe Phillips, who's the founder of Integrated Healthcare Solutions. Joe, thank you for joining us. Love to hear a little bit about your story.
Thank you. Thank you for having me. So my name is Ingrid Phillips. I go by Joe. And I started an MIH program for the city of Chesapeake about 7.5 years ago now. I no longer work for Chesapeake. I've turned over because I founded Integrated Healthcare Solutions, many fire and EMS agencies around the globe, and just teach them how simple it can be to start an MH program. My background is in the military. I was a paramedic for 22 years when the Navy used to run our own private ambulances in our own installations. After that, I came to work for a fire department. I've absolutely loved it. And when I started this journey, my fire chief said, I would really like to start an MIH program, and I didn't even know what that was. And similar to Chief Lemery, I started just with me, and I found somebody to help me, and we started going out into the field, and we grew our program, and our program grew from just two to enjoy this work. It's very rewarding.
I love that. Really bootstrapped it from the ground up. And quite a pioneer too, in terms of when you started your program and how you've been able to see it flourish since then. So one of the questions we would love to ask you here today is, did you have to get into that payer relationship and negotiation for reimbursement? If so, how did that go? Or what would you want to tell the audience when it comes to those types of transactions?
That's a wonderful question. So when we first started, I was told that we were going to be fully funded by our city's tax revenue. And we were given a budget to work with, and I had to stay within those lines. We were very fortunate that we did not have to rely on payer or private pay. So we had to put together a pilot very quickly. And when we started the program, we presented it to our city council. And I will tell you that one of the biggest lessons was to keep it simple. You never want to overcomplicate a program, because the people who are willing to give you money, they'll just be confused. Payers want to understand one thing: what problem are you solving? And as soon as we focused on a clear message, which was keeping people safe at home, supporting our fire and EMS crews, and reducing avoidable 911 calls, the conversations got much easier. And they want to see proof. Another major lesson was the value of relationship building. Payers just don't want to respond to metrics. They want you to tell a story. Small wins, consistent communication with partners and payers, and transparency just goes a long way.
Yeah, absolutely. I agree. And that data piece, I think we've heard it now from two of you so far, but and Nora. So really doubling down on collecting data and knowing how to tell that story to stakeholders. Are you seeing any new trends in the work that you're doing now, working with different departments, or any new trends in reimbursement? Anything maybe we haven't touched on you wanted to make sure we brought to the surface today?
Well, some of the trends that I'm noticing is aside from the rural health transformation initiative, we're just noticing that policymakers and payers are now recognizing that non-transport care is actual health care. So it's a good thing that we are seeing reimbursement now, and now we just have to figure out how to get all the agencies in line and with standardization and supporting the fact that to I'm sorry, and supporting each other, that MIH is one and the same with EMS. You know, we cannot do this without the other. MIH serves for the purpose of keeping our fire and EMS staff away from the frivolous calls and having to be safe and having to respond to actual emergencies.
Absolutely. And one last question to you, Joe. What common pitfalls do you see agency facing when they're first starting to set up their programs?
I love this one. One of the most common pitfalls I see is that agencies try to build too big, too fast. Departments sometimes create a very long wish list for their program before even proving one outcome from their service line, and that leads to burnout. Another pitfall is understanding the administrative side, documentation, follow-ups, metrics, compliance. Without planning for that work, the field staff can become very overwhelmed. Um, Finally, do prioritize the well-being of the providers who are delivering the care. When we take care of our public safety workers, they're able to serve the community at the highest level. And so if we take care of them, they'll take care of the community in return, and everybody wins.
Love that. All right. Well, thank you so much. We're going to hear from you in just a little bit as we get into that cross-panel discussion. But for now, I'm going to transition over to Deputy Chief Steve Bowie. Thank you for joining us from San Jose. Would you mind just giving us a little bit of background about what you all are doing out in California?
Yes, and I'm actually going to tell you what I was doing in Oregon because we're in the early phases of doing it a second time. So I've been with the San Jose Fire Department for a year and a half in this role. I spent 26 years prior to this at a fire district up in Portland, Oregon called Tualatin Valley Fire and Rescue, a large special district that surrounds the city of Portland. And in that, I was the EMS chief there my last 6 years before coming down here. And in 2018, launched a pilot there that went from kind of a similar story to what Joe talked about. I started off with one single role paramedic that I pulled from our single role paramedic ranks and said, hey, I want to try this. And put him in the field, building the administrative side, and then doing some field home visits for about 2 years, while I continue to try to socialize this program. And when I left the organization, we had 14 members in our advanced practice community paramedic team with 5 units in the field every day doing that work. And so it's evolved over that time period and is continuing to grow. Even after I've left, I've continued to be in contact with the person that took my spot, as they now are trying to do some nurse practitioner and PA work combined with the community paramedic in the field to do some advanced treatment type work, which I'd kind of always envisioned when I was there. So San Jose, I'm in the beginning. I've done the same thing. I'm just repeating the process that I did with my former fire chief of socializing the need for doing that in this community that is so overrun, and so the volume here. Our department runs about 120,000 calls a year, and we're probably 10 stations short. So we have many heavy assets that are running 6 to 8, 9,000 calls a year on the EMS side and fire side. So we have to get a different tactic. We cannot continue to do what the American Fire Service does, which is do the old. We're gonna solve all these problems with more fire engines and fire trucks versus an alternate type of EMS delivery model, which we're now going down the path of starting a pilot here. We're really close to one more meeting with electeds to getting the green light to begin a pilot here, and so we'll do it the same way that I did it there.
Well, that's actually a great transition to our first question here. So coming on a year and a half ago, you saw a program get started and be successful. So what knowledge did you bring to your current leadership and stakeholders to get their buy-in that this can work for this community?
Yeah, just to me, anybody that's going to do this, especially in a large organization that's traditional. So if you're coming into an organization like I am here where they don't have single role paramedics, so now you'd be trying to start this using suppression personnel to get buy-in with this. I can't emphasize enough the success that I found previously, and you have to do it, is you have to have labor on board early. Labor has to be part of it. They're your best, I call them the best champions in the field, because I think as the chief in Tulsa talked about, that the line paramedics, once the line firefighter paramedics start seeing the impact that these units can have, just in kind of the classic, what I call the firefighter mantra, what's in it for me, is that they don't have to go on those low acuity calls that they really can't solve. They're not trained to solve them. And the more that you start showing them and talking about it in that way, I think you end up with them being champions to kind of help you convince an administration and stakeholders to go down this road. So I think labor early is critical. And then I think you got to be honest. And so one of the key things in my former department was the first thing the fire chief said to me when I proposed it was, where are you getting the money? Who's paying for this, right? And the other famous, I love this, that fire chiefs often say when I speak about this in other places, is this is a public health problem. This is not our problem, right? But if we're going to wait for public health to solve what is actually has a big public health component, but is not funded, as we know, we're going to be dealing with these patients, and we're going to be dealing with the effect of not dealing with them, which is poor mental health for our responders, because this is these type of calls are not ones they can solve, and it's very overwhelming. I think from a mental health perspective, we're starting to see that more. People speak about it in that way. Down here, we're 2.5-hour wall times or ambulance offload times at our hospitals. So you talk about the impact that programs like this can have on not sending people there to add to that time, which in turn keeps heavy assets available for all hazard response. You have to get the fire chief and the electeds to see it from the other type of value and be honest that you're not going to get reimbursement. So if you're starting off where you can't start a program without having a reimbursement plan that provides you 100%, unfortunately, that's going to be a real difficult road to go down with electeds and fire chiefs, unfortunately.
That makes sense. Well, speaking of funding, what ways, I know you just talked about, upfront, it's really hard to get that reimbursement piece, or maybe even funding at all. If you're not fortunate enough to find one of those grants or other means that we mentioned earlier, what was your experience with finding the money and being able to keep going?
Yeah, I really targeted that reality. So I was after general fund fire district money to start it. I was not going to start on grants. My department that I came from was very restrictive of grant use. And so while I did pursue that, and we did do some work with a DOJ grant that focused on opioid interdiction and opioid response, so we got a little bit of funding through that with partnering with another fire department. I was focused initially on, we just have to do this with internal funds. But what I tried to use was a strategy of how do I show the value that you can't put a dollar figure on. So I actually learned this from, it wasn't mine. I'm not the inventor of this, but I talked to some other fire chiefs who were successful in actually looking at fleet costs. And so I was trying to find those other intangibles that the electeds and the fire chief could see beyond the speak about mental health and about the right thing for the patients was, so if we took these calls out of the system, out of a busy system, could I increase the PM schedule on the heavy assets and maybe save money with fleet? And I was able to get those dollar figure assessments from our fleet department on how I could show that if we did this, then it would be this much less that we'd be spending in another space. So that was one of my strategies. Another one that I think is really underused, and I think that was one of the questions we were going to talk about today, is I looked for a lot of community partners in different spaces. So when I left to come here, I was really close to signing a contract with one of our colleges that has a social worker program to where I would take their social worker students that were getting MSWs into my department. They would fund a full-time social worker to be a case manager for us so that their students could do internships with us and help us with our social determinant patients. And then I would in turn almost get a free social worker that I didn't have to pay for through general funds. And I could then use general fund to buy other support staff or pay for other response teams. So I think we had probably 4 different colleges where I was beginning those talks with. I think there's a lot of opportunities to be creative and think outside the box and figure out how you get funding. Maybe it's not the funding just straight money to use for FTEs, but it's funding that gets you other positions and other capabilities that your program's looking to have. And I think that's a untapped resource in the communities that we probably all serve if we think outside the box.
Were you able to do that? Or I know San Jose is still kind of new to the scene, but were you able to do that in Oregon? And have you been able to secure that type of support from your local schools in San Jose?
Have not started those conversations because we're so new into the yes, we can do this.
Mhm.
But what we have done is leverage, and this is partly some part of your other question too, was are there other funds that public health has that are probably being siloed where we're not sitting at the table? And I think Joe said, and I can't agree with her more, that it's all about relationships in this game. And that's relationship with hospital systems, with community partners. I'm sure the chief in Tulsa that talked about the fact that they have private entities paying into the program came all from relationships. And so what I've created in my time in San Jose is trying to figure out in the public health between the county and the city, where's all the siloed grants and money sitting that people are not working together to figure out a more of a holistic plan to spend it. And we're already finding that out. So there's obviously a lot of people know about the opioid funding that's out there in a lot of cities, but a lot of those cities, in my experience, are they're spending the money without asking the stakeholders are actually involved in addressing the problem to be at the table to talk about how to spend it. So we're getting that group together in San Jose. Let's talk about how where this money is being spent, and can we collectively maybe look at all that in one place and say that's the priority and get the fire department to have a seat at that table. So I'm working through that currently. So I think we're actually going to be successful in gaining some public health and opioid money to help start the pilot here, which is huge because I'm not sure the state that the city's in, we'd be able to start the pilot without that seed money coming from other city sources or state sources. So I think that's super critical for organizations to do.
Absolutely, I agree. All right. Well, I'd love to have all the panelists join. We've got about 8 minutes to the top of the hour. I know that IFC is going to want to close us out. So we probably have about 5 minutes to get a few more questions out to y'all. I do not see the chat, so I apologize if anybody is entering anything into the chat and we haven't addressed it. But I'll go ahead and carry on with some of the predetermined questions we have for our experts today. And any one of you, please feel free to come off mute and answer this if you have a strong opinion or story that maybe you'd like to share with us. But what's one thing you wish policymakers better understood about the financial realities of MIH or CP programs?
I'll just answer that if there's one thing that I wish policymakers better understood about the financial realities of MIH programs, MIH provides a cost-effective approach to healthcare that improves healthcare delivery. So we're going to reduce the actual cost of healthcare and improve that service delivery. We all know this in this room. The story I always tell of we had an address. These individuals from September till December 15th, they had called 911 187 times. 187 times we sent fire trucks, ambulances, police officers to this house. Never once were we really solving that issue. And until we address social determinants of health, until we change the model or the status quo, we were not solving that issue. And once we did, no longer was that address calling 911 anymore. And it's because we changed our approach. We changed that model. And Just think of all the expenses that went into sending those apparatus and sending that individual to the hospital all those times, all that money. When we approached it a different way, we were able to save a lot of money. And most importantly, we were able to help that individual get the right care. And that's what MIH can do. And I think it's a very exciting time right now because I think there's a lot of momentum behind MIH and what this can do, not only for our departments, but for our communities.
Absolutely.
And
Thank you.
I would just add on that what the chief was talking about. I think the most powerful data. So you asked how our department's using data to tell their story. If you want to start telling the story, to start socializing it, run the data on out of service time for the heavy assets on those, your top 50 high utilizers. That's easy to run through whatever EPCR platform you have. Pull that up, get your CAD data. You should be able to do that with help, even if you had to get somebody from the outside to do it. And what I made was these charts that showed, not by name, obviously, patient one, 190 calls in 6 months, this many hours out of service, and this many rigs that's out there. And you want to talk about the city councilors don't really like to hear that in their area they didn't have a fire engine for that amount of time with water. So that's, like, to me, that's super black and white. It's a great storyteller where I'm not even having to talk about the value that the chief just mentioned to the patient and the right resource to the right. I mean, I'm just showing that just the effect on, if you only care about fires, here's the effect on fires. Here's the effect on the rest of our abilities to serve in the community. And that's easy data to tell a story. I think to me, that's an easy start. It's like a low hanging fruit.
Indeed. Yeah. Chief Joels, are you cutting me off? I see you're on camera. I want to be very respectful.
No, not. I wouldn't dare. I have the ability to see some of the questions, and there's just a couple. I was going to just read one. Do the panelists have any thoughts on movement to change the mindset from reimbursement to compensation in the MIH space? And then I'll add to that on the political side of things. What are some things that people are seeing to help motivate some of the states to be able to be more helpful in getting MIH off the ground in your states?
Yeah, I mean, I'll answer that second part real quick. We've got I think this starts reimbursement, and when you're really trying to get everybody together, it starts at the state level. I mean, agencies and departments within the state have got to come together, have common language, have common data systems that they're talking about, and illustrate the value. And so for Oklahoma, we have, and we've got a lot of rural, urban. Everybody's kind of working together at a higher rate. And we've got the Oklahoma Healthcare Authority is on board and motivated and excited. And I think a big challenge I see a lot of people is, communicating the value of MIH, and we've been able to do that. And so for us, it's getting the state on board is really going to help escalate the MIH programs and get those off the ground a lot faster. And we've been able to do that. In regards to reimbursement and compensation, I don't know if somebody else wants to answer that. I think that's a great discussion. I really do. I think it's a great discussion. And the most importantly is we must get paid for this work, because by implementing this work and we're able to do that, we're going to reduce the healthcare cost. Chief, I don't know if you have anything, or Ingrid, if you'd like to chime in on that.
So as I mentioned earlier, we were fully funded, by our city. And so to tell the story of what has actually happened, we first had to find out, well, what is our biggest issue in the city? So of course we performed a health needs assessment. We found like the top 5 issues going on in our town. And actually our city is it's a pretty, medium-sized city. We have about 450,000 residents living here. I'm sorry, 250,000 residents living here. And we discovered that our daily non-transports were showing anywhere from 28 to 30%, and they were turned off. So we started digging and found out that, wow, we have a very rapidly rising senior population in our city. Our first approach was to find out why those calls are being turned off. Why are 30% no transports? And that's a big problem for us in the fire service, especially here in Chesapeake, because no transport, no pay. And so 30% is quite a large number. When we found out what was causing that, we found out that, of course, about a very large percentage of that was fall related. or lift assist related, which took our firefighters and our EMS crews out of service, to go to these calls. We found that they were just helping them, like good public safety, workers do. And then we were going back to the station and we were, saying, okay, well, they're fine. So when we got after that 30% that wasn't transporting, we were able to then come to our council later and ask for that continued sustainment of funding, because we were able to prove a year later that 30% of no transport turned to 12% of no transports, because we were proactively keeping people safe in their homes. So again, I know I talk a lot about keeping it small, but the best advice that I ever received, when I started out very early on, was go after the low-hanging fruit. Find out what the biggest problem is in your area and find a solution for it. Find out how you want to solve that problem, and then gather information and show your city, show your town what the outcomes are of all your efforts. Be very, very transparent. The more support you have from where you live, the more that you will be funded and sustained and reimbursed by, the lawmakers who support your program. But you have to show them. And again, not just the data, show the faces, show the people that you're actually impacting.
Well, we thank all of you for taking some time out of your day to share your wisdom and knowledge with us. It was very impactful. Thanks for everybody for attending today's webinar. Thank you, Sarah, for moderating. We appreciate everything that PCG, I'll get it out. One of those, maybe I need to have a stroke webinar next. PCG does for us, the IFC, and then local entities as well. Everybody have great holidays. We hope to see you soon on the next one. Be safe out there, and good luck to your programs. Thanks for attending.
Thank you.
Good work, everybody.
Thank you.
Have a good day.
You too.